Hi, my name's Jackie Edwards and I'm a nurse consultant in burns based in Manchester in the UK. I'm going to talk to you today about managing infection in burn wounds, the role of antimicrobials. Whilst the mortality in burns has declined over the past few decades, this is largely due to improved treatments such as early excision and grafting of the burn wounds, continuous feeding to treat significant nutritional deficiencies and advancements in critical care. However, despite improvements in treatment, infection remains the leading cause of morbidity and mortality in large burn area surface patients. Loss of the protective skin barrier as the first line of defence and defects appearing in the patient's immune system make the burn-injured patient an ideal medium for bacterial growth. The widespread resistance of microorganisms to antibiotics threatens to be a future medical disaster. Antibiotic resistance among a wide variety of human, bacterial and fungal burn wound pathogens, particularly nosocomial isolates, limit the available therapeutic options for effective treatment of burn wound infections. This could have a significant impact on the outcome of these patients in the future. In terms of infection in burns, immediately post-burn, gram-positive bacteria from the patient's own skin flora or the external environment can colonise the burn wound. In the first 2 to 3 days post-burn, then host gram-negative bacteria from the individual's gastrointestinal flora can also start to colonise on the wound. And then after 2 to 3 days, you get colonisation of the burn wound by yeasts and fungi, especially if broad-spectrum antibiotics are used. So there are many organisms that can cause burn wound infection. As mentioned on the previous slide, the first to cause a problem are those gram-positive organisms, such as Staphylococcus aureus, MRSA, coagulase-negative staphylococci, enterococcus, and vancomycin-resistant enterococci. Next come in the gram-negative organisms, and things like Pseudomonas aeruginosa, E. coli, Klebsiella, Enterobacter, and Acinetobacter. And then lastly, we start to get fungal and viral infections, and Candida and Aspergillus are very common in burns, but you can get Fusarium and Rhizopus, and in viral infections you can get herpes, cytomegalovirus and varicella zoster. So MRSA, methicillin-resistant coagulase-negative staphylococci, vancomycin-resistant enterococci, and multi-resistant gram-negative bacteria that possess several types of beta-lactamases, including the extended spectrum beta-lactamases, or ESBL, and AMP-C beta-lactamases, and metallo-beta-lactamases, or MBL, have been emerging as serious pathogens in hospital patients. Pseudomonas has become increasingly difficult to treat, with resistance to most available beta-lactams, aminoglycosides and fluoroquinolones. So Pseudomonas is one of the real problems in burn wound management. Pseudomonas causes adhesions to host tissues, nutrient acquisition, immune system evasion, killing of host leukocytes, tissue destruction and bloodstream invasion. It carries a host of innate and acquired characteristics that resist antimicrobial countermeasures. The other big problem is Staph aureus, which again causes adhesion to host tissues, immune system evasion, destruction of host cells, proteins, coagulases, and superantigens. And it has a known resistance to countermeasures such as methicillin. So these are extremely common bacteria, and they are common because these pathogens have many virulent properties which influence their ability to cause colonization and infection. Antibiotics, however, are not routinely used for prophylaxis in burn injury. Studies have shown that using systemic antibiotics as a prophylaxis agent against infection in burn patients has no clinical benefit, as they do not improve clinical outcomes when compared to topical antimicrobial therapy. Conversely, they may influence the development of complications such as antibiotic-associated diarrhea, increase the resistance of bacteria, and by doing so make any subsequent necessary treatment of burn patients with systemic antibiotics more problematic. So therefore, this is not routinely administered in burns. So what's the problem of antimicrobial resistance? Why are we concerned about it? Antimicrobial resistance is the sophisticated processes that pathogens develop to combat therapies that fight against them, i.e. antibiotics, and occurs on a genetic level either by mutation or by the introduction of a new genetic information. So what does that actually mean? So what it means is that some pathogens carry a genetic determinant that is stimulated by and is capable of mutating in the presence of an antibiotic. Those that cannot generally mutate are then able to accept antimicrobial resistant genes from the mutated pathogen. And those pathogens that cannot accept the mutated genes are killed off. So what this really means is the strongest survive. So only those genes that are able to accept either a mutated gene or mutate themselves, therefore continue to live within the wound, and that means that overall these genes are resistant to antibiotics. So what actually influences the development of antibiotic resistance? The WHO have identified a number of areas, and first of those is excessive and irrational use of antibiotics, which I think is fairly well known, and hopefully the use of antimicrobial stewardship will help to reduce this. But there's also antibiotics in our food production. We've also got increased survival of patients who've been seriously ill with infection. We've got lack of use of effective infection control measures such as hand washing and patient isolation. We've got increased use of invasive procedures and prosthetic devices, and generally we're living longer and therefore are more likely to become ill at some point. The WHO suggests that antimicrobial resistance threatens the very core of modern medicine as we know it, and have issued a global action plan. They suggest there are key influences on the development of antimicrobial resistance, which I've alluded to. They have also published the top 5 most urgent categories of pathogens for which the development of newer antibiotics is urgently needed. It is not surprising from a Burns point of view that Pseudomonas aeruginosa is in priority 1 listed as critical, alongside Acinetobacter and Enterobacteriaceae. By 2050, it's predicted that there will be 10 million annual deaths from infection and economic losses of over $100 trillion. So this is a really useful algorithmic approach to antibiotic therapy for wounds based on Lipsky's work. Antibiotic therapy is appropriate for clinically infected wounds. Most wounds, and especially burns, are polymicrobial, thus requiring broad-spectrum antimicrobial regimes. But these should be narrowed down to a definitive regime based on the culture and sensitivity results of a wound swab or tissue culture. Unfortunately, some clinicians think they should continue antibiotic therapy until healing occurs, but this could be months and there is no evidence to support this belief. So following this, if you had a wound that was clinically infected, you would collect your tissue sample or your wound swab. You would start them on some empirical antibiotics based on your local protocols. You'd then review that culture. It may be that it's colonized, and in which case it's not affecting wound healing, or you've got a defined result which you then would identify which antibiotic is appropriate for which pathogen. So what is antimicrobial stewardship, or AMR? It is the organisational system-wide approach to promoting and monitoring judicious use of antimicrobials to preserve their future effectiveness. The British Society for Antimicrobial Chemotherapy say it should be the right antibiotic for the right patient at the right time with the right dose and the right route, causing the least harm to the patient and perhaps more importantly for future patients. So as antimicrobial agents have been used indiscriminately since their introduction, changing prescribing practice will be difficult and require adherence to strict new guidance to effect any change. That is why AMR programs have been initiated and funded to try and ensure success. However, because there is a diverse range of antimicrobial interventions used in managing wounds, it is imperative that clinical practices should minimise the possibility of selecting resistance to all of these therapies. With ageing populations, increased prevalence of diabetes, rising costs of wound treatment and diminishing prospects of developing new antibiotics, Novel approaches to optimizing and conserving all antimicrobial interventions in wounds are indicated. It is imperative that clinical practices should minimize the possibility of selecting resistance to all of these topical antimicrobial therapies. Most AMR programs do not include topical antimicrobials used in wound care, something that is raising concern across many wound organizations. So what are topical antimicrobials? These are dressings or products that have an antiseptic agent incorporated in them. Previously, antiseptics were known to damage healthy tissue, but recent advantages in antiseptic technology has led to the development of a number of products that are less harmful to healthy tissue, but are highly effective at destroying pathogens. And when I talk about topical antimicrobials, I'm not including topical antibiotics. So what makes an ideal antimicrobial dressing? Well, we need a broad spectrum of activity. They need to be bactericidal, not just bacteriostatic. And what that means is they need to actually kill the bacteria, not just stop them replicating. You need a rapid but sustained activity. They need to be suitable for use on broken skin. They need to be non-irritant and non-toxic and easily soluble in a non-toxic carrier. They should not be inhibited by body fluids or exudate, and they should be easy to use and store, and also obviously cost effective. So a wide spectrum of antimicrobial agents are used in managing wounds. While some of these are antiseptic solutions for cleaning wounds, many are incorporated into medical devices. Not only do they need to be effective against bacteria, but they need to provide the optimal conditions to facilitate wound healing. So you see these products impregnated into hydrofibers, into foams, and a whole range of other modes of delivery. So looking at these products, first of them is chlorhexidine, which disrupts the bacterial inner membrane and causes coagulation of cytoplasmic components. But it has started to develop some areas of resistance, and there is a risk of anaphylaxis. Povidone iodine, which has been around a very long time, it causes oxidation of thiol groups, binding to the DNA, and reduction of fatty acids. There is no known resistance at the moment, but it can affect renal and thyroid dysfunction, and again we've heard of allergic reactions. Cadexima iodine, again similar mechanism, and again has to be used with care in renal and thyroid dysfunction. Octenodine, it causes disruption of bacterial membranes and has no resistance and no known toxicity. And DAC technology, which is more recent, is however bacteriostatic. So it binds and inactivates the bacteria but doesn't actually kill them off, but has no known resistance and no systemic toxicity or allergenicity. So PHB is a product that's been around quite some time. This causes disruption of bacterial membranes, but there's not yet currently any resistance been identified. And generally systemic toxicity and allergenicity is rare, but hypersensitivity can happen. Reactive oxygen species, which uses hydrogen peroxide, these form free radicals which oxidize thiol groups and cause breaks in DNA strands and increase cell permeability. Again, no known resistance has been noted in the literature, and there are no known problems with toxicity or allergenicity. Silver, which is the most common antimicrobial used, interacts with thiols groups in membrane-bound enzymes and binds its DNA to cause breakage and inhibits cell division. Unfortunately, there now are a number of reports in the literature around resistance to silver, and this is consistently being investigated. It has got some question around systemic toxicity, and certainly in larger areas like burns, you can get ageria and ageriosis. And then honey prevents cell division in staphylococci and disrupts outer membranes of gram-negative bacteria. It binds to DNA to cause breakages. Again, no resistance to bacteria has been isolated, and no systemic toxicity or allergenicity. So clinicians need to be aware that products vary according to their concentration and availability of the active ingredients, their mode and duration of action, and their ability to handle exudate, odour or pain. And products should be selected specific to the needs of each wound. Unfortunately, the clinical evidence to support the use of conventional antimicrobial agents in wound healing is weak, and evidence of antimicrobial efficacy in the real world is sparse. So it's difficult for clinicians to make those decisions. So of that long list of antimicrobials, probably the one you're least familiar with is the reactive oxygen species. Reactive oxygen radicals, which are directly antimicrobial, include anion peroxide, hydrogen peroxide and hydroxyl radicals. The antimicrobial action is against the thiol groups in enzymes and proteins, DNA and bacterial cell membranes, which are broken down. Reactive oxygen species gels have slower release activity over a prolonged period of time. They also have potent antimicrobial activity against bacteria, fungi and viruses. They're rapidly active against all gram-positive and gram-negative bacteria, including multi-drug resistant strains. And this goes further than most of the other antimicrobials. And also of interest is they're also effective against biofilms in chronic wounds as well. And so some examples of reactive oxygen species dresses include honey and flaminol. So what exactly is flaminol? Well, flaminol is a hydroactive broad-spectrum enzyme alginogel. It consists of hydrated alginate polymers in a polyethylene glycol matrix embedded with enzymatic complex of glucose oxidase and lactoperoxidase, with guaiacol as a stabilizer, or for ease of saying it, GLG. Its mode of action is a two-step mechanism. Firstly, glucose oxidase forms a peroxide, which is similar to honey. And then secondly, lactoperoxidase transforms the peroxide into oxygen radicals and hypoiodite radicals, or ROS, reactive oxygen species. These radicals destroy the bacterial cell wall, and the guaiacol stabilizes the radicals. Low concentrations of the GLG enzyme kills antibiotic-resistant bacterial strains without being cytotoxic to fibroblasts and keratinocytes. Flaminol comes in two versions, the Hydro, which is for low to moderate wounds, and the Flaminol Forte, which has got more alginate content and is for moderate to high exuding wounds. So how does this apply to burns? Traditionally, many burn services have used topical antimicrobials regardless of burn depth. In the past, there was a heavy reliance on things like Usol and then latterly more flamazine. Now a much wider range of topical antimicrobials are available to clinicians. It is important that we don't abuse them as we have done antibiotics. If the risk of infection is low, then do we really need to use a topical antimicrobial? And in deeper burns, where we remove the dead tissue, do we need to continue to use antimicrobials until the wound is healed? Think about the depth of the wound and the potential toxicity or resistance the product has. It's important as practitioners that we know what we are using and the effects that the product has. So if we look at something like a superficial or epidermal burn, there's no risk of infection. So do we need to put an antimicrobial on that? Probably not. As we move into superficial dermal or superficial partial thickness, again, there's a low risk of infection. Do we really need to use an antimicrobial? As we start to affect the dermis in mid-dermal or deep dermal, then yes, we do need to think about the use of antimicrobial dressings. And certainly when we're talking about full thickness injuries, it's a definite need for those dressings. But as I say, as we debride those wounds, whether it's surgical debridement, whether it's by autolysis or other means, then once that dead tissue is removed, then the risk of infection decreases. And so we need to think about that rather than putting an antimicrobial on from the point of injury to the point of healing. So let's talk a little bit about clinical practice. So this is my clinical practice in my clinical area, and we use a range of different products to prevent wound infection. And the sorts of products that we have used or use, we use currently Flaminol Hydro and Flaminol Forte. We still do use Flamazine rarely, but it's usually at the request of one of the consultants, or one of the staff just slips back into what they used to do. And we also use a product called Optenolone gel in smaller burns. Only once a wound is demonstrating clinical signs of infection, so heat, redness, swelling, pain, etc., do we then actively treat with some of the other antimicrobials, and the two that we use the most commonly are Acticoat and Keracontact. So why have we moved more away from Flamazine to Flaminol? Well, for Flaminol, there is no evidence of resistance, whereas the evidence for silver resistance is growing. Both of the products are cooling and soothing, so patient satisfaction is equal on both of those products. They're both easy to apply and come in large tubs, which makes them useful in the larger burn. Flaminol is safe to use in pregnancy, also on neonates and patients with underlying conditions. And that's really where we start to get into some issues with Flamazine. There has to be caution in pregnancy, can't be used on neonates, and it can't be used with some other problems like renal or hepatic disease. The other key thing is that Flaminol doesn't mask the wound. And that is the biggest problem with Flamazine. Flamazine creates a pseudo eschar, which makes wound assessment quite difficult. So when you balance up both sides of the argument with these two products, then logic tells us that Flaminol should be the product of choice. And for that reason, in that staff don't have to think, are there any underlying conditions, and also that we can have good wound assessment, we have chosen to go with Flaminol. So I just thought I'd show you a few case studies. The first is a case of a 78-year-old lady who, still at that age, was working in a chip shop, which sells fish and chips, and she spilt some boiling water onto her feet. Appropriate first aid was administered for 20 minutes, and then she was admitted to our burn service. And the initial pictures you can see, certainly if you look at the top right picture, doesn't actually look like there's a lot of damage. And that's because that's a very early image before the burn has declared itself, which it tends to do around 48 to 72 hours. This lady was initially treated with Nexabrid, which is an enzymatic debridement tool, which is becoming more and more commonly used in the UK. And then afterwards cadaver was applied. So she had no surgical debridement at all. Cadaver was applied. She went home after about 4 or 5 days, but was then unfortunately readmitted 10 days later with significant pain. So this picture is a picture of the same wound prior to commencement with Flaminol Hydro. You can see it's quite unhealthy granulation tissue, although the sole of the foot has healed, which is very common because of its thicker skin, and around the ankle you can see there are, it's still quite an unhealthy bed, and extends up the lower leg. So she had Flaminol Hydro put on there with a silicone NA dressing because she had so much pain. You can see quite shortly after, 5 days later, that wound generally looks healthier. 10 days after that, the wound predominantly up the calf is healed. She's just got some smaller wounds around her ankle. 3 days later, you can see that again, smaller wound, much healthier looking. And then this is at the end of the month, where this wound is largely healed. She's just got a small area of shear up on her calf on a previously healed area and a couple of small dots. But this wound, for all intents and purposes, is healed. This lady managed with this product no problem. Her pain immediately was reduced. She was able to mobilize and was able to tolerate the dressing very well. The second case is an 80-year-old male who had a fall at home. He had multiple underlying medical problems, hence the reason for his fall, and he had burns to his right arm and scalp. He was admitted to our service because of his multiple underlying problems. He'd had excision but no closure on the 22nd of October, which sounds a long time, but we were trying to stabilise his underlying medical health problems before we could take him to theatre. And after that, it was treated conservatively. So you can see just prior to his discharge on the 9th of November, that's what the wound looked like. This chap then disappeared to follow up, which is very common, unfortunately, with our cohort of patients. We picked him up again in January the next year, and this is the wound at the point when we applied Flaminol Forte. It was quite a wet wound, so we applied the Forte to it. You can see that 12-13 days later, the wound is smaller and healthier looking. And then another 10-12 days later, you can see that the wound is significantly improved. It's much healthier looking, it's smaller, it's flatter. But again, we lost this patient to follow up. And unfortunately, we've never been able to track him down. However, both of these cases show that this dressing has a positive effect on these wounds. On this instance, we used a silicone bordered foam dressing, which we commonly do because they adhere well to areas on the scalp. So in conclusion, morbidity and mortality from infection in burns remains high. Antibiotic resistance is a major issue, and therefore prophylaxis should be avoided. We need to consider antimicrobial stewardship, not just for antibiotics, but for antimicrobials as well. And because of that, antimicrobials are likely to become much more important in wound care. However, there is some resistance developing to some antimicrobials, so we do need to be careful how we use them. And for that reason, we need to understand the range of antimicrobials available and their efficacy in managing or preventing wound infection in burn patients. I hope that's been of use. If anyone has any questions, we will be having a Q&A session after this, but also here is my email for any further questions. Thank you.